Morning.
Thank you for being here. I'm peering around the corner at everybody. Welcome to this fantastic symposium that we have planned this morning. And welcome to Medical Home Development Group. This is one of our 5 sites located throughout the city, 1 in each quadrant of the city and 2 in Northwest. And we're happy to host you here at our Northeast location. My name is Dr. Melissa Clarke. I'm the VP for Population Health and Provider Contracting here at Medical Home Development Group. And other than welcoming you here today, which I'm very pleased to do, I'm going to spend just a few minutes talking about the work that we do here at Medical Home Development Group, and also just setting the stage for our discussion. And then also giving a chance for all of you, who are all distinguished guests, to introduce yourselves. So here at Medical Home Development Group, one of the population groups that we take care of is very unique. Those individuals affected by opioid use disorder. We all know the magnitude of the opioid epidemic. It's been declared a public health emergency nationally, as well as a state of emergency in 6 states. And here in the District of Columbia, the rates of death from opioid use disorder have eclipsed that of homicide in the city. And in Baltimore, our neighboring city, it has the highest rate of opioid use in the state. And Maryland is one of those states that has declared the opioid epidemic a state of emergency. Dr. Edwin Chapman, our distinguished CMO, has almost 20 years of practicing addiction medicine and has been using buprenorphine medication-assisted therapy to help stabilize individuals with opioid use disorder, and has been treating it not as a moral failing, which for many years it has been viewed as, but rather as a chronic disease to be managed in a team-based approach. His success has really allowed us to develop an innovative, patient-centered medical home ambulatory care model to address the needs of this very special population. Its foundation is the use of population health to identify gaps in care and be able to close those gaps in care and improve health outcomes for this population. Individuals with opioid use disorder, and in our population, that's oftentimes in the critical ages between 40 and 60 when those chronic diseases tend to surface. They not only have the same gaps in care as everybody else, the need for colonoscopies, mammograms, diabetes screenings, mammograms, lung CTs for smokers, of whom about 90% of the population are smokers, but they also have higher rates of HIV and hepatitis C, and importantly, because they have also had histories of trauma, either emotional, physical, or both, they live with untreated PTSD, depression, and anxiety, which create a toxic stress environment and give rise to social limitations in meeting their health needs, such as transportation, housing, health literacy, food security, among others. MHDG, Medical Home Development Group, is a multi-specialty IPA, Independent Physicians Association, with expertise in addiction medicine, primary care, pediatrics, cardiology, social work, and behavioral health. And we employ a chronic care model to address addiction. We're an NCQA recognized PCMH, patient-centered medical home practice, taking a population health-based approach to close gaps in care, the ones that I mentioned before, and help individuals work through the social issues that deter them from accessing and benefiting from the services that are available to them. So in a short 1.5-year time frame, we've had some significant achievements. One, we have a chronic care management provider designation with DC Healthcare Finance, the Medicaid provider in DC, through a CMS-funded program called My Health GPS. Under that program, we manage the majority of individuals with substance use disorder within the program. And that's one of the reasons why is because we are the largest provider of buprenorphine services for Medicare and Medicaid patients in the city. In addition, we use an integrated electronic health record that's connected to the DC's Health Information Exchange to be able to receive real-time alerts on our patients' population, on our patients' healthcare utilization. We also have care coordination agreements with 3 of the methadone clinics in DC to provide primary care and care coordination. We have an effective working partnership with a consortium of over 70 faith-based institutions, the Leadership Council for Healthy Communities, and we have Dr. Sullivan Robinson here, who represents that organization, among others, to access social services which have previously been untapped for our population. And in conjunction with LCHC, they were the lead, we received a grant to do engagement, patient engagement and health literacy work through the Sibley Foundation. We have a representative from Sibley, Dr. Sanders, and that grant allowed us to conduct classes for over 50 to 60 participants to go through a curriculum called Be Health Empowered. And finally, we have an academic partnership with Howard University School of Medicine and Pharmacy to examine the genetic, psychological, and sociological determinants of addiction, and allow us to develop more effective strategies to improve the health outcomes, and that's through a grant from NIMHD. And we have Dr. Georgia Dunstan and Dr. Howell here in the house from Howard University. So the results of all the work that we've been doing have allowed us to have a 78% retention rate in care at 1 year. It's a statistic that dwarfs the average 10% retention rate of detoxification alone. We're seeking to continuously improve our whole person approach to care through crafting strategic partnerships, and that's one of the reasons why we're here this morning, to hear from all the various experts across the board and really look for synergies in ways that we can boost and enhance the work that we're already doing. Now last night, just to switch subjects a little bit, I had the good fortune of seeing the performer Babyface. Does anybody know who that is? And he performed at the National Symphony Orchestra last night with them at the Kennedy Center. And he has honed his craft over many decades, starting off as an R&B performer, prolific composer. He's composed over 100 top 10 hits. And he performed with these brilliant musicians last night at the Kennedy Center, who were truly produced together a masterful evening of music. And it struck me as I was on my way here that I was about to be engaged with individuals who over their career have become masters and honed their craft. And they started off together at Howard University Hospital back in the early 70s as classmates, and have been reunited here today to really lead our discussion. And hopefully, as they work together, we're all going to create something that's greater than the sum of its parts. So I want to just especially acknowledge Mr. Tom Wilcox, former head of the Baltimore Community Foundation. There you are. Dr. Robert Blum, MD, MPH, PhD, HU School of Medicine, 1973, Director of the Johns Hopkins Urban Health Institute. Dr. William Wade, Junior, Howard University School of Medicine, 1972, Master Historian and the son of Henrietta Blacks and Calvin Hills Turner Station Dr. William Wade Sr., his dad, who graduated from the Harry in 1943. And last but not least, Dr. Edwin Chapman, our Chief Medical Officer of the Medical Home Development Group.
Good morning, y'all.
Good morning. Good morning.
Today is really a follow-up of 2 dates, October the 7th and November the 18th. October the 7th was the day that my wife's cousin, who, by the way, if it had been left up to him, we wouldn't have gotten married because he told her not to. But that's how things change. But year ahead of me in medical school. But my wife and I attended the Johns Hopkins 8th Annual Memorial Symposium for Henrietta Lacks. And it was the first time that it was acknowledged that his father was the physician in the community that discovered her cancer and referred her to Johns Hopkins. But you'll see that program here, and you can actually pull the whole thing up on YouTube. But it was a day that you just, I just couldn't believe what happened. And I was there filming it with my camera, not thinking that they had their own closed circuit. I won't go into his story. You can watch it for yourself. I'm not going to ask him to repeat it because it's too emotional. But following his presentation, a young man got up and said, I went to the same high school that you went to. And they got up and hugged each other. And then he said, I went to Howard too. And, maybe I was concentrating on my filming and didn't quite catch it. And, people look different from years ago. So about a week later, I got this phone call from Skip. And he said, you remember Dr. Blum that spoke? He was in your class. And I said, Bob Blum? It was like a revelation. So we spent the day, literally, in Baltimore, touring the station, and the experience, looking at where his father practiced, because in my mind's eye, he was the son of a doctor at Howard, and you think that, he had this fabulous house, etc. There's 2 row houses in the community. Not unlike the other housing in the community. And so we began to talk about how healthcare was practiced in that era. The doctors lived in the same neighborhood, the teachers lived in the same neighborhood, everybody knew each other. So the story that he told really was a throwback to how health care was practiced. His father knew his patients other than their disease. He didn't see them as a hypertensive or diabetic. He actually knew who they were, where they worked, etc. We don't always know that. So that's what we're trying to recreate, I think, in this accountable health community years later that came out of the Affordable Care Act in terms of how do we, now that we live separate from our patients, really get to know our patients? How do we get to learn those social determinants that Reverend Tucker talked about that account for 80% of health outcomes? And so the idea was, when I realized that Bob Blum, my classmate, was the director of the Johns Hopkins Urban Health Institute, how could this be such a secret? Why doesn't everybody know this? Why isn't everybody in D.C. going to Hopkins to try to, collaborate? So we spent this day on November the 18th together, and Skip said that Bob was going to bring a friend. And that's how I met Tom Wilcox. And I sat there and listened. I made copies of this videotape. I'm going to give each one of you a copy. Skip already has it. Girls, I mailed them to them. But the conversation, the fluidness, the freedom, the experience, how did you get to Howard? How did, what was your impression, etc. It's so important in us building this whole community approach to taking care of patients. And I thought about that last night when the federal government shut down, and we really have to do this. We really have no choice. Also, yesterday, I understand the president extended the emergency opioid declaration that really did not create any new programs or any new money, etc. So we're pretty much on our own in terms of making this happen. So that's really all I'm going to say. But I think that we have an opportunity. We certainly have the need in Ward 8 and Ward 7 east of the river. When I give a talk, I draw a line right down the middle of the city, and the idea was, we got a grant from Sibley Hospital, which is a Johns Hopkins affiliate. So obviously they are interested in the east side of the city and what happens over there. How can we make that work? How can we learn and connect all of this information? Because we have all the expertise, we just have to be organized. And Reverend Tucker said this ad infinitum that we just need to do it. So Melissa?
Melissa?
Where's Melissa?
Dr. Clarke.
So I'm going to introduce Dr. Wade, and then we're going to get some remarks from Dr. Blum, and we want to hear from Tom Wilcox and the extraordinary work that he's done. I mean, this is 200 years of history, mistakes and successes that we can build on. Other than Skip, I can remember, partying with him a little bit and so forth, but I think, when you graduate from medical school, everybody goes their own way, and most of the folks you never see again. But to come back together almost 50 years later and to have the opportunity to merge those experiences is extraordinary.
So, I came to Hopkins from Minnesota. I came to Minnesota from Howard. So I'll tell you a story of my transition to Minnesota, then back to Baltimore, and then a little bit about the Urban Health Institute. So I fell in love with pediatrics during my medical school years. And I fell in love with pediatrics primarily because of 2 or 3 children who were in there, all of whom had terrible disease and all of whom who died. But they had overwhelming impact on my life. And I chose to go into pediatrics. I chose to go to Minnesota because of a person who became both a friend and mentor of mine. But my first day at Minnesota was orientation for interns. And it was absolute culture shock. We were all handed white coats. And this auditorium of about 400 people, not just pediatrics, but all of the new interns put on our white coats. And I looked around the room, and I had never seen so many white faces with white hair in white coats in one place in my entire life. It was just stunning to me. It was not at all my experience of what medicine was or is. I stayed at Minnesota for quite a number of years, over 30 years, and headed up pediatric and adolescent medicine program, and then came to Baltimore. My experiences in Minnesota and the contrast with my experiences in Baltimore were stunning. In Minnesota, in the years that I went there, in the years that I lived, there was a tremendous political transformation. But there was an investment of the community and community resources into the city of Minneapolis and St. Paul that I came to expect. When I say investments, I mean corporate investments and human investments. There was a perspective when you grow up and live in the most harsh climate that the United States has, that you don't pass someone on the road whose car is stuck. You stop and help them out of self-interest, not out of any sort of charity. It's self-interest, because one day you're going to be stuck, and you're going to need them to help you. And you have to create a culture of doing that. The culture of Minnesota, some of you may be familiar with Land O'Lakes butter. Land O'Lakes is a farm cooperative. And the basic principle of a farm cooperative is you don't have enough money and enough land to buy a combine. And I don't either. But you know, if the 5 of us got together, we could buy a combine and we could all till our land and harvest our land. The notion of a farm cooperative. And that was the social construction of community that I worked in and I came to expect. And that was not the world that I moved to in Baltimore. In Baltimore, I did not see the kind of corporate investment in the city. I saw philanthropic investment. I saw a lot of wealth, but I did not see the kind of corporate investment. One small example, in the years that I was in Minnesota, it was the center of technology at that time, and also of agribusiness. And on an annual basis, the president and CEO of General Mills would change places for 3 days with the principal of one of the schools. That principal became the CEO of General Mills for 3 days, and this guy became the principal of the school. A human investment that I wasn't seeing in Baltimore. The opportunity to come to Baltimore, to be at Hopkins, and to head up the Urban Health Institute really has been an opportunity to take some of the research that I have done and see how do we apply this. The research that I have done my whole life has focused on one question. Why do so many kids, because all my world is children and adolescents, why do so many kids reared in terrible environments do well? It was never a mystery that kids faced with the greatest disadvantages do poorly, but the majority of them do well. And the majority of them don't become addicted to drugs. They don't become pregnant at 14. They don't go down. They do well, and they get on with life. So what did they have that their brothers and sisters didn't have? And it really is about creating human supports and human connections. So the work that we do through the Urban Health Institute is about creating supports and connections. We aren't a clinical service. Hopkins has huge clinical services, and they don't need one more clinical service. We are not a substance abuse prevention program or a pregnancy prevention program or a left-handed prevention program. We are about creating positive cultures and environments. So the kinds of things that we do, some larger and some smaller. We have worked with community foundations and community organizations to create a linked early child development center with the school. Hopkins was going to be developing or redeveloping for many years. They were in this process, a community school in East Baltimore that became the Henderson Hopkins School. But we know from all of the research on child development that you can't start at age 5 or 6 with kids who have sustained 5 or 6 years of trauma and disadvantage and expect them to go on, no matter how wonderful the school is, to be successful. We said you got to start at day one. And so with support from the Weinberg Foundation and with support from the involvement of people who really knew what they were doing in early child development, the Maryland Family Network, we developed an early child development center which starts at 6 weeks of age. These kids enter school at 6 weeks of age. They continue in the early child development. They go on to kindergarten and through the 8th grade. There is a pipeline for kids going through. And now the Weinberg Foundation has expanded this and is now supporting 4 additional early child development centers linked with schools. There's one such program here in DC. Educare has one such program. But developing things such as that. We also know that the history of the relationship between Johns Hopkins University and its immediate neighborhood has at best been less than good, and often significantly worse than that. And that was actually, predating my coming, was an impetus for Hopkins to set up the Urban Health Institute. And one of the things that we also know is the way you break down distrust is by doing 2 things. One is showing up. Showing up. Being present in the community at times that are important. A small but very important thing. A second is to sit at the table, break bread, and come back over and over and over again, and be willing to hear people share their anger, share their frustration, and over time, through a process, you build trust. Trust doesn't happen because you say, I'm here to help you. Trust happens because I am there repeatedly and I show up. And at some point, you build trust. One quick story of a pastor whose name I won't mention because you probably know him. When I first became the director of the Urban Health Institute, they said, oh, you must meet Pastor so-and-so. And I said, great. So I set up an appointment, set the date, went out to meet him at the church. He didn't show up. I wrote him a note. I said, I left it on the church. I said, I'm really sorry. I must have had the date wrong. And I'll call you. We'll set up another time. This went on a second time. Showed up. He wasn't there. Third time, I said, look, if you'd really rather not meet, please just tell me. And I'm cool with that. I can live with that. But I don't think I got the date wrong twice. So the third time showed up, and he showed up. And in the years that followed, we've become extremely, not only good friends, but very, very close collaborators. About 4 years ago, there was an article about him in the Baltimore Sun. And a guy who worked in his organization told the story about his experience identical to mine. And it was clearly an issue of his saying to me, non-verbally, are you going to keep coming back or are you going to give up? Because if you give up, I'm not investing my time in you. And that's really, I think, part of the lesson that I have learned from working in Baltimore. Hopkins has had the wonderful opportunity of having a CMS, Center for Medicare Services grant to really build the services and supports for the highest end users, particularly people with cardiovascular disease. And the funding of this just wound down. So as you know, many of those folks are the same as your clients here, are those that have mental health problems, those that have housing and social problems. And a hospital is not terribly well equipped to deal with all of the complexity. And so what we worked to do is build a network of community clinics and community, not only clinics, but organizations like Sisters Together in Reaching, which work with women who are HIV infected, with a Men and Family Center, to build a East Baltimore network that worked together with the inpatient services at Hopkins Hospital and Bayview to provide the supports and networks. Facilitating that. One final thing that we do, and then I'll stop, and that is capacity building. So we've been very fortunate. 2017, we were able to launch a program that we call the Bunting Neighborhood Leadership Program, because of the major donor, the Buntings, that supported this. And what we do is that we, through a significant self-identification process and then interview process, identify young community leaders. And the functional, operational definition that I use of young is anyone who is a year or more younger than I am, is young. So young community leaders who have real promise. And we accept them into an intense training program. We pay 20% of their salary. So we pay their organizations for them to come. We offset that with the expectation that you will be here every Friday for a year. And it is intense leadership training around financial management, around interpersonal skills, about community development, around public speaking, about writing op-eds and things of that nature. And the first cohort graduated in December. We had 6. The next cohort starts in a couple of weeks, and we'll have 8 new community leaders. And our goal is to build a network of people working at the grassroots level who not only have the passion and drive, but have the skills to achieve social change. So I'll stop, but that's a little bit of the work.
Thank you very much, Dr. Blum.
Well, mine will be short because I don't know why I'm on this program, number one. I really haven't done anything innovative in life. I mean, I graduated from Howard, did a residency under Lester Henry, went to practice. Now I practice in a couple of jails in the Hampton Roads area. So, look, I haven't done anything. I think, really, I think I just told a story about my father who was, I found out was Henrietta Lack's physician. Of course, it wasn't in the book because he had died by the time she wrote the book. And he didn't know what happened. And I didn't know anything about what happened until I read the book. I grew up in Turner Station where Henry X grew up. So when I read the book, that I would not turn the station to people that I kind of grew up with. I know. I said, and I asked the black son, was my father your doctor? He said, oh yeah, he was all right. The black son, he was my doctor. He's the one. So I didn't know anything about it until I read the book, and so I haven't done anything. I just told the story. So I don't have really, for me personally, I don't have much to contribute to this. You know, I'm just interns, practice medicine.
Well, we're delighted to have you, and I think the perspective that you can bring practicing in the jails, because what we're really talking about is sort of building that accountable care community where we have concepts of how people transition and become returning citizens, and they have unique sets of challenges as they come back into the community. Many of our patients are returning citizens, and we have to also talk about ways that we can build bridges to facilitate those kinds of connections to make sure that people are maximized to have success in their health despite other challenges, major challenges in their lives. And then, Mr.
Melissa, let me just interject something.
Yeah.
Skip is just like his father. You know, I remember his father, and I think we had a picnic, family picnic, and his father was very quiet and unassuming. This was just a part of what he did, and the story that he told. Skip is now certified to do buprenorphine. He understands exactly the impact, the need for transition from when and he's told me about the women who were in jail who were addicted to opiates. Those babies those mothers have to have medication-assisted treatment, either methadone or buprenorphine until they're delivered, and then they need support to transition back into the community. So he's already done that. He's going to do his part. And my team has already been down there before we even had any idea about this. They went down there 6 months ago, and I told them you need to meet Dr. William Wade Jr. And they met with him, and he was telling history stories. I mean, he was telling stories. He's been a historian ever since I knew him. What we miss, if we don't know our history, we cannot connect the dots. It's lost. And what he did was he actually brought this all together. You know, when you watch that tape, you will see something that you've never seen before in 15 minutes. That is extremely important. The reason why we're here is because of his historical context and understanding.
Very much. First and foremost, I am clearly not a doctor, and it reminds me of deep pain in my life and my inadequacy, because both my father and grandfather were, both grandfathers were doctors, but I had this barrier called organic chemistry, and that was a barrier I was not able to overcome in spite of having great privilege. So I'm your lesser in every way. I also am glad to be able to speak. I'm reminded of my mother, who said that God gave Tom a stutter so the rest of the world would have a word in edgewise. So I will try not to talk too long. I count November 18th, when I was able to spend a day with Dr. Blum and Dr. Wade and Dr. Chapman, as one of the 5 most important days of my life. And along with getting married and when we were able to adopt our children, and I hadn't seen Dr. Blum. We went to a school in New York at different times together 50, 60 years ago, and I hadn't seen these people. We found all of these extraordinary connections, but there was an emotional, intellectual connection, a kind of hope connection, and I think we established that day. I certainly felt this overwhelming privilege of being with these great men. But if Dr. Wade thinks he doesn't belong here, given organic chemistry, I really don't belong here. But I will say that what I've been able to learn in Baltimore over the 17 and a half years that I served the Community Foundation is that institutions can change, that conditions can change, that recovery is possible, albeit really difficult, and that myth can be busted, and that indeed maybe there's even hope after retirement to do something important. And I speak about institutions being able to change because the community foundation that I inherited and was able to serve was a white institution. No African American professionals on the staff, and very token African American representation on the board. And today, the majority of the board is African American. Before I left, we totally changed the nature of the institution. I was the only straight white Anglo male over 30 on the staff. And with my successor having just been named, and she is a young woman who grew up in a Baltimore neighborhood and got herself a PhD at Duke, an African American woman, there are now no straight white Anglo males on the staff, so one could say that VCF has arrived. And I'm very proud about any role that I might have played as we tried to tackle the combined issues of race, equity, and inclusion in taking a look at how we could best serve the region that we did indeed, and were able to increase grant making annually from an average of $5 million to $25 million. And also that conditions can change. And once again, it's about early childhood. In 2002, we determined that according to the Maryland measurement for school readiness, only 28% of Baltimore children were ready for kindergarten. And how could we possibly expect them to get to the finish line if they weren't at the starting line? So we set a goal, and some people said we were insane, probably accurate, but of having 90% of the children ready for kindergarten by 2017. And they moved the goalposts and they changed the criteria on readiness, as they should have. Now the criteria better reflect what you really need to be ready for kindergarten. But it's easy to say that we beat that 90% goal. Yeah. And the particular angle that the Community Foundation took was to believe that within our schools and within our neighborhoods, there was the opportunity to help children and families without resources get them such that their children could be emotionally and constitutionally ready for kindergarten through something that I know you have in the Maryland counties in the greater Washington area, which is Judy Centers. And we were able to go from having 2 Judy Centers in Baltimore. We were able to raise private funds and get it matched with public funds to go from 2 to 11 so-called Judy Centers, which are based on the idea that people from the community with training, social workers, can connect with families as children are born and get them in touch with the resources they need and with the school principals, such that over those 5 all-important years, families can make up for the trauma, the inadequacy, all of the barriers that we all know so well that people face in an urban environment. And there is now clear criteria which demonstrate that the combination of public pre-kindergarten, full-day public pre-kindergarten, accompanied with the comprehensive wraparound services provided in a Judy Center, is all students in those environments will outperform all other ways of preparing children for kindergarten. Those conditions could change, and that the public and private sector can work together. On a very personal note, I will say that that recovery is possible. Addiction visited our family in a mean and ugly way, and my wife and I and our daughter together have 34 years of recovery, and we have a son who's got 55 days of recovery, having been working at it for 15 years. This is the longest route he's ever gone, and who knows what'll happen tomorrow, but today he's got that level of recovery. This would not have happened without the kind of services that people in this room provide. So when I speak about humility before you, I speak with a great sense of deep humility and appreciation for the kind of work you're doing, and an understanding of the challenge. It's very clear to me that Christopher, my son, with all the privilege he has, can't find a way to recovery. How do we expect children who don't have those kind of resources to get there. We must expect it, but man, is it difficult. So I just find this, this humbling and interesting. Also, I love the fact that we busted a myth in Baltimore. We ran a capital campaign to address this Judy Center issue and to give us some endowment to be able to have permanent resources in Baltimore. And we were told that we couldn't raise more than $50 million. The professionals came in and analyzed it for it. But we knew we needed $100 million to do what we needed to do. And we actually raised $103 million versus the 50 they said we could raise. But most significantly, we were also told that we shouldn't bother turning to the African American community because African Americans give through their churches and they're not interested in giving to broader needs, and certainly not broader needs in which they would have to partner with the white community and the white corporate community. And I'm really pleased to say that of those $103 million that we raised, $11 million came from the African American community, ladies and gentlemen. And this just shows that when you do trust, and when you do include, and when you do change, that indeed good things can happen. And the kind of humility, and we had $2 million gifts from $3 million gifts from African Americans who grew up in the most severe poverty that you can imagine. And so hope, in spite of what we read in the headlines, hope is possible, and I was able to experience it that day. And so my final thing is that maybe there can be life after retirement by knowing these three distinguished doctors as well as I was able to that day on November 18th, Dr. Chapman, and now meeting you. Maybe in my retirement period, I can make a difference somewhere. And there's a better chance that I can make a difference and improve my tennis game, even though I really like it. So it's an honor to be here with all of you, and I look forward to knowing you all better.
Thank you very much, Mr. Wilcox.
My name is Michael Lowry, and I'm a 64-year-old addict. You know, I came from doing the drugs with my father 30 or 40 years ago by stealing his drugs. When he found out I was on the drugs, he didn't help me get off. Only way I got off these drugs was through Dr. Chapman. He helped me. I've been with Dr. Chapman for a long time. I'm one of the oldest patients, too. And I met this man a long time ago, and he helped me. You know, and it helped me get my life back in order. Because I'm an audio video tech and a chef. And I tell Dr. Chapman sometimes when I come in here, I be on the road with both these singers and artists out here, and I do all the audio work for them. But me doing the drug, I wasn't doing a good job then. Right now, I'm excellent. I've been off the drug for at least 12 years now, and I'm happy. You will not see me put another hole in my arm or sniff another heroin. Heroin is not heroin, it's fentanyl out there, and it's killing my brother. And I just came from a funeral yesterday from a friend of mine. He's 27 years old, and he took the fentanyl. He just came home, and he had hit the drug, and he had a heart attack. The fentanyl in that killed him. That's one of the reasons that I would not go back there. Heroin is not heroin no more. It's another poison there. It's a poison now. It's not heroin. It's poison. But what they're doing now, they're cutting it with all kinds of junk, and we are not going for the high no more. We're just doing it. You think we're getting high? You're not getting high. All you're doing is killing yourself. By me being with my wife, I've been married now for 30 years with her, and she was a DC police officer. By me going to Dr. Chapman, I saved my marriage. Because I couldn't keep doing drugs and be with the police way. I loved him more than the drug. So right now, being with Dr. Chapman have told me I got a good life. Because I was going down here. Now I'm on top of everything now. You wouldn't believe what I be doing. Because I work at the Verizon Center, Plus, I do a lot of catering for the artists when they come in town. I get a whole lot of recommendations from them guys. When they come in town, my name is called every time. I don't care. My wife will tell you, I be gone for 2 or 3 days, all night long. But she don't mind because she know one thing. She know I'm not shooting drugs. She ain't got to worry about me no more. Because she know that I'm not going that way no more. I have made it, and I'm going to stay this way. Dr. Chapman, thank you.
I'd just like to comment that Mr. Lowry is the first patient that we identified and actually wrote up in a published paper using pharmacogenomics. So one of our focuses is the fact that we think that certain patients, or we know that certain patients need higher doses. We all need different doses of medication, we know that. But that through pharmacogenomics or precision medicine, we can identify patients who may need higher doses, because all across the country, there are different rules and regulations and dosing and how long patients should stay on medication. But in precision medicine, which again is a part of the Affordable Care Act, we think that we found a specific allele that makes patients of African ethnicity metabolize buprenorphine faster, and that's what that poster is there. We actually presented it at Howard, and we have 144 patients in a series that Dr. Dunstan and Dr. Etienne at the School of Pharmacy are looking at. So I dose them blindly based on symptoms, and they come behind and then do the pharmacogenomic testing. So it's not just the care coordination and everybody in this room. It's what Melissa brings to the table, and Dr. Dunstan and the School of Pharmacy. But you're looking at, as far as I'm concerned, Mr. Lowry's history for us.
Truly, I am honored to be here. The challenge that, just to give you a quick backdrop, I'm a Washingtonian. My people came up from North Carolina in the early 40s, and I'm a product of DC. But the challenge that I grew up in it was rough. The projects was a correlation of the ending of the war when Roosevelt, but then the good thing about it was that we had good parents, and they were hard workers. My mom, that could not read or write, I would never tell people this if she was still alive. But somehow we can't figure it out to this day. How did she used to work for the old people drugstore in the back, but then somehow she went into GSA. And we tried to figure out, well, who filled out the applications. Lo and behold, the last year of Eisenhower, she made it into the White House as a maid until her retirement. The reason why that is so important, that when you look at, especially in the African American community, the infrastructure of the projects was not a destination, but a through run. And that we started, when I got, like I said, I was a bad little boy. Loved to do unauthorized use of cars. So I went to Cedar Knoll, because this is important. Cedar Knoll, then I went to the National Training School, always from unauthorized use of a car. And that's the reason why I have 5 cars now. So I don't have to steal them anymore. And so I wound up in the youth center. If you remember, the Youth Act was supposed to be therapeutic, and it had a 5010A, 5010B, and a 5010C. And so they gave me the conventional one was a 5010B, 5 to 4 months to 5 years. But out of that process, it was a person, Sergeant Trotter, and he said, Mayfield, you're gonna talk yourself in the White House, and knowing you're gonna talk yourself out. So when I did get out, a friend of mine was killed by a police officer, May the 1st, 1967. So this is nothing new, right on Minnesota Avenue. Out of that, we started really trying to get the police officer indicted. Somebody knocks on my door, and I had heard about him. It was Marion Barry, and asked, how can we help? Out of that, we created one of the most successful programs this city has, this country has ever seen, Pride Incorporated. And out of that, and so to give you the Reader's Digest on the back end, just for me being in, I was just talking, Dr. Chapman, to one of your patients back there, and we were talking about what jail does to you, what incarceration does to you, my good friend right there. And we were talking about the challenge of when you come out. Jail condition you to live in jail. It's an animalistic environment. And a lot of times these good brothers cannot turn it off. And so the challenge that we have, and I forgot to say I was in DC government, and I really was proud of my tenure in the Department of Human Services. I deal with some of Dr. Chapman's patients. I go to revocational hearings with an organization called Destiny Pride. And the challenge is that we have to begin in that initial assessment how much this individual has been damaged by jail. If you're not going to do that, you're always going to constantly see the revolving door. And so just like on the medical side, whereas comfort care and curative care, the insurance company will do their assessment predicated on what your ailments are. And when you start billing them, if there is no coordination of the services and what you have, they will not pay. So what I submit to all of my good friends that are here, in that initial assessment, when I talk to a lot of, I can use you, right? That when you start talking to these individuals can be in their 50s, in their 60s, and they look at their life in the aggregate, and they become totally overwhelmed. I try to get them to look at it in the micro and try to build capacity. And that word we must hang on to. If we're not able to build capacity within these individuals, it is always going to be the revolving door. And so I think that sometimes we even have to build bottom up, almost becoming a de facto parent, until Dr. Chapman does one tremendous job. And I don't know why my journey took me that way, but I am able to communicate with these individuals. I go through it, and I think that when you begin to look at it, the opiate individual, like I was up at Howard with Dr. Chapman, and the drugs of the 60s, and this is important too, the drugs of the 60s, mescaline, all of those drugs. And I was really tight with Dr. DuPont. Do y'all remember him?
Robert DuPont.
Yes. You the only one? And y'all supposed to be what? He was the opiate, huh?
Yeah, he's an opiate man.
Oh my God. Y'all some neophytes. I don't know who the hell I'm talking to. But Dr. DuPont in the 70s, you see, that's when it started really taking off. It leveled off, but it started right there. So the issue that is before us is how in that assessment of the individuals, what lane do we put them in? Because that is so important. Otherwise, you're going to constantly see the revolving door. And so I was telling the sister, when Decatur Trotter said, Mayfield, you're going to talk yourself into White House. When Decatur Trotter became the state senator, he said, didn't I tell you? I saw it in you. The most important thing, what I was standing on the shoulders of those giants, my mom and my dad. What you are now seeing, especially in the African American community, that whole process has broken down. You should never ever see a great grandmother in her 40s. Let me do that again. What does that mean? That somebody had a baby at 12. The next one had a baby at 12. The next one had a baby at 12. Well, where's the shoulders of the giant of the parents they supposed to be standing on? Just recently, the mayor was having a meeting, a press conference did you see it on TV yesterday? She was having a meeting about a shooting. And then we heard the ambulance and everybody going. So she went from that press conference to another shooting. So what you are seeing, youngins do not even begin to have the capacity building within them. But I'm really appreciative to that brother right there, because I do work with him. He is forward thinking. And so I want all of you other clinicians to take all of this into consideration, or otherwise you're going to be pimped on like a prostitution.
Thank you.
We got phase 2 coming up now.
Okay, you say now I ain't asked to talk anyway. They ain't gonna pick me out.
Thank you very much, Mr.
I've been
Mayfield.
put out better places.
We want you to stay. We definitely want you to stay.
Hi, my name is Desiree Townsend, and I am a patient of Dr. Chapman. He's really, really good. I am recovered for 4 years. I've been in and out, but I'm letting you know it does work. And I feel so good about my life now. I'm not in and out of the system anymore. Thank God. So let y'all know it does work. And I am so grateful to you. And I'm glad to be here to let everyone know that.
Just moved.
Oh, I just moved to the new apartments on 4000 Benny Road, up the street, over the bridge. It's brand new. All because of being clean and sober. Yes. Right.
Very much, Ms. Townsend.
Thank you.
Good morning. First, I'd like to thank God for allowing me to wake up and even be here. Let me get that out of the way. Secondly, I'd like to thank Dr. Chapman for inviting me. And lastly, I'd like to thank my wife for persuading me to get up this morning. See, every day ain't a good day for me. And in spite of being on Suboxone and being in therapy, every day ain't a good day for me. So I ain't gonna come up in here telling you that I'm joyful every day, because I'm not. I'm really not. And
Move a little bit so everybody can see this wonderful person and making it all possible. Very good. There
see,
you go.
words are meaningful. You know, I was telling my wife, I was listening to all of you speak, and words like impact, You said that you hadn't done anything. Well, you have. You sitting in that chair, you showed up. Going back to the words that he used, showing up. So that means something. I heard somebody use the word lesser than. See, I feel like that a lot of times. First of all, let me give you some clarification. I'm not a Washingtonian. I'm 64. I'm an addict. I was born in Henderson, North Carolina. Came up here when I was 15. Academically, I was fine. But I wanted to fit in. I went to the street. The streets raised me. I heard Mr. Mayfield speak about prison, because if you speak to most gentlemen or women who come to see Dr. Chapman, at some point, we went to prison. And like he was saying, there is a lot of damage. The damage starts because most things that you learn in life, you learn from a book or behavior. They don't teach you how to do time. The judge tells you to step behind that green door, and you have to adapt. They don't give you a book when you get off the bus down there. They give you a knife and tell you to survive. See, don't nobody tell you these things. So when he was speaking about damage, there is some damage. So how do you deal with that? I went to jail. I did 9 years in prison initially for robbery. I came home, went there 76, came home 1985. I went back 6 times as a result of my need to continually use heroin because of my inability to feel greater than lesser than. I survived it coming out. People would look at me and think that I was okay. No one knew what I was dealing with inwardly. That's why I was telling you about my wife. She'd have been with me 25 years, so if anybody know me, she's just seen the good and the bad, other than my parents. My grandparents raised me, so when I came here, I had moral fiber. I knew what right and wrong was. You understand? I knew what church was. So in growing up, whenever I found myself in terrible situations, I could always reflect back because I had a moral compass. He spoke about women that are having babies. They don't have a moral compass. So if you don't have a moral compass, how do you know what's right and what's wrong? When we live in a small city, and the impact of this city is far greater sometimes, and we choose to ignore it. We really do. We would rather just look at the news and say, well, that doesn't concern me. But if you are part of this community, if you are part of this city, then it does concern you. It does affect you. Because if nobody has a moral compass, like he spoke about the mayor and the people shooting, do you think that they cared about that? These children don't have any clue about what life and death means. So where does that start? This thing says something about the father I never knew. I never knew mine, other than seeing him. I wanted to be like him. He was a pool player and a hustler. You understand? Most of the good things I know about life, I learned through watching women. You understand? A lot of times we don't understand the roles that women play in our lives. You understand that stability that they give you coming up. When you go to prison, I want to reflect back to that real quickly. When you go to jail emotionally, wherever you were at that point, you stop growing emotionally right there. Put that there. If I'm 21 when I go to jail emotionally, my 22nd birthday, I knew nothing about being able to enjoy it. Because in prison, you have to live in that world. You can't cry. You can't show emotions. So in that, you try to find a collective body of men that eventually you can share those emotions with. Because I don't want you to think that prison was all bad for me, in spite of. Lawton had a lot of good programs. They had a lot of good men that were there that have came in the street and went on to do good things, have become good fathers, good mentors. But we ain't gonna solve this in a 5-minute transition. You know what I mean? I heard her say something about transition. I heard Mr. Mayfield, I'm glad that he's working with it because the DC government and the federal government, they represent 2 different entities when you're talking about rehabilitation. Back in the old days, the DC governments, even though they had programs, their position was to put you on parole. If you had 2 or 3 dirty urines after 5 months, they send you back. Because the revolving door meant that you only had to do 69 months. You could come back home. The jail was 25 miles away. You understand? Methadone was the only thing that they knew. Dr. Chapman, he does the Suboxone program, and I want to jump into that real quick because it is a successful program, and I wish other doctors would take the same roadmap that he's taken. This hasn't been an easy journey for him dealing with this, but he listens intently, and he understood, and he continues to understand the need for not just the boxing, but therapy. When you come in the door, they meet you wherever you, whatever needs you need to be addressed, that's where they try to meet you at. Therapeutically, psychologically, like Mr. Mayfield was saying with his programs, because you need those components. Because when you are in prison, you are damaged. I'm gonna give this up because my wife, a lot of times don't get a chance to speak, and I do want her to be able to talk because she has a lot that I think that she could render to those women who might be in similar situations dealing with a guy who's been to prison and who's an addict, because it's a dual diagnosis kind of situation, and you know, emotions go up, come down, all that kind of thing. But and I want to thank Ms. Clarke for allowing me to even get up to speak, because I didn't know. But Mr. Mayfield, he covered a lot, and I hope you were listening, because prison is a big issue when you're talking about dealing with drugs in this city. And I heard him say this, and I'm gonna let go, because a friend of mine is having a funeral today too, and he died as a direct result of this fentanyl. See, this thing is a killer, and if we don't find a way to get out in the street and bring people into settings like this so Dr. Chapman and other doctors can treat them, it will continue. Thanks for allowing me to speak.
Thank you, Mr. Bennett.
Not really. Thank you, Dr. Chapman, for inviting my husband and myself to be here this morning. I am not a speaker, but I believe I'm going to have to learn to be a speaker. My husband and I have gone through some tough trials and tribulations, and I too have a story for others who don't know how trying it is to be in a home with an addict on a daily basis, trying to get him to change his thoughts about life and about himself. With that, I'm going to not say anything else until I get well prepared, and I appreciate being here this morning.
So thank you so much, Mrs. Bing. I'm going to actually open it up now to discussion, and I just wanted to just briefly interject. 2 out of our 3 speakers said that they have had funerals in the past 2 days, and I remember as we embarked upon the care coordination program and we were enrolling people, one of the people I vividly remember having a conversation with, he was like, yeah, I'd love to be in the program, but I want to go home and talk to my girlfriend about it, and I'll tell you next week. And he never came back because he died. And this is real, y'all. And I understand Dr. Chapman's passion, because people are dying every day. And, you know, we have these intellectual discussions, but it really is about finding solutions, building synergies, and really coming up with interventions that really can make a difference. So on that note, I want to open it up to the distinguished folks. We've heard themes of building human relationships. We've heard about the impact that the prison system has on this whole process. We've heard about early childhood interventions and the importance of that. We have expertise here in maternal medicine, OBGYN, genetics, gastroenterology, mental health, many mental health and social work and behavioral health individuals in the room. So please, feel free to comment and ask questions of each other. Anyone want to go first?
I'll go first.
Yes.
One thing comes to mind for me. My first degree was in early childhood education. And we were taught 20 years ago that by the time the child is 5 years old, 1/3 of his personality has already been developed. This is before he goes to a school. So much of that has to take place in the home. And a lot of times now we're focusing on those parents, even if they're single parent households, to have the information and what should be taught from birth up to 5. Incarceration, and I was looking at Howard, and Howard brought out the point that between the ages of 18 and 24, how many people think, question, what percentage of young people between the ages of 18 and 24 are incarcerated? Raise your hand. Throw some numbers out to me. Anyone? What percentage do you think between 18 and 24 that particularly black men and women are incarcerated?
12%.
20.
35%.
52.
Okay. It's less than, it's around 18%, if at all. The rest of those children are in college or in school. They're doing real well. So we think of the community, you know, oh, you look at the community and, you know, so on and so forth. That's not true. They're doing well. We're doing well. And we need to continue. And thank you very much for what you shared with the group. But things are more positive than you would think. And we ought to build on that. Thank you very much.
I've been dying. I've just been dying. I'm Larry Gordine. I'm not going to hold you long. But I think, you know, for me and what I really see up there and what we need, I think, going forward, it all comes to leadership. And what I see represented in the front of the room is this years and years of this expertise, commitment, passion, and leadership. What we have to do is scale, and I like what Mr. Wilcox was saying about your leadership model, but we also have to find a way to take what everybody up there, Dr. Howell, and what you've done, and Dr. Dunstan, and what y'all bring to the table, and how do you get that to the immediate generation of healthcare clinicians? There's somehow when y'all came up and came through the ranks, there's a gap in there somewhere between where y'all are and what you've done and what you've accomplished and what is currently being done. So, I mean, as an example, we understand this community inside and out, etc. And the one common thread in this community has always been the lack of capacity, particularly primary care and medicine, right? When everybody's running away from Ward 7 and 8, it takes a Dr. Chapman to run toward 7 and 8. How do you get that down to, how do you get more Dr. Chapmans? How do you get that down to the next generation? How do you get that to the resident fellows who are coming out of medical school and out of school of social work and out of school of pharmacy? How do you get them to run toward the fire? Because at the end of the day, it has to come through that point of care. And in anything we can do to build capacity and build resources and build support around the point of care, everybody at some point is going to see a doctor. And for most of us, and particularly folks in this community, seeing doctors on a routine basis. And there's so much more that can be out of that experience. It's just not happening because the resources are not there. And there are really some innovative models on there, but how do we get this community grand round series? How do we keep this going? And there's some folks that are doing some innovation, you know, like Jan Desper-Peters and Black Mental Health Alliance. I mean, she's got your vision, but how do we connect your vision, your expertise, your influence, your power? How do we connect that with the current generation and Jan Desper-Peters and the Black Mental Health Alliance? And I'd like to have her just say a little bit about the model that she's trying to implement. I mean, like literally on her own, with no help, no resources, and she really don't have access to you, is what it really comes down to. And she's literally building the bridge and building a model that's going to integrate behavioral health, addictions, mental health, and mental health. And she's been working on it for the last 5 years, you know, and she's bringing on with Dr. Duvernay. Dr. Duvernay, and she's going to collaborate with Dr. Duvernay. Dr. Duvernay. And Dr. Duvernay is a social worker, PhD in healthcare administration.
Counseling psychology, licensed professional counselor.
Bam. And she has worked at all levels of the government. She's worked at SAMHSA, HRSA, and she's worked at the local level, all things substance abuse. But here you got two dynamic leaders who have committed and who are trying to make this happen, but they're just not getting the support. They're just not getting access to you, Mr. Wilcox. They're just not getting the chance to sit down with you, Dr. Bloom. And they really need to sit down with you, Dr. Wade, okay, to scale on what they're doing.